Welcome to this video entitled, Opportunistic Infections in Kidney Transplantation. Renal transplantation is the therapy of choice for end-stage renal disease, ESRD, in children and adolescents. It is successful in 90% of recipients and allows most children the best opportunities for normal growth and development and an almost normal lifestyle. Despite the overall success of renal transplantation, infection remains the major cause of morbidity, graft loss, and mortality in renal transplant recipients. Effective immunosuppressive regimens have reduced the rates and hospitalizations for graft rejection after renal transplantation, but rates and hospitalizations for bacterial and viral infections seem to be unchanged or increasing. Prednisone-free maintenance immunosuppressive combinations with tacrolimus, mycophenolate mofetil, and sirolimus help maintain graft function, but they also may increase the risk for development of infections, including post-transplantation lymphoproliferative disorders, abbreviated as PTLD, papillomaviruses, and invasive fungal diseases. These infections can be managed successfully if detected early and treated appropriately. In this chapter, a general approach to renal transplant recipients is presented from the perspective of the infectious disease specialist. Specific, detailed information regarding the diagnosis and management of each particular pathogen can be found in the respective chapters in the section of this textbook dedicated to infections with specific microorganisms. We will now discuss pre-transplant evaluation. The role of the pediatric infectious disease specialist in the care of a renal transplant recipient ideally begins during the pre-transplantation period. Before the patient undergoes transplantation, a thorough history and physical examination should be performed, with a focus on evaluation for evidence of an active infection that may require immediate therapy or, rarely, preclude transplantation, as shown in box 73.1. The history should be comprehensive but focus on the details of any history of previous infections that may re-emerge during the post-transplant period, including urinary tract infections, abbreviated as UTIs, mucocutaneous diseases such as herpes simplex virus, abbreviated as HSV, infection, systemic illnesses such as tuberculosis, chronic infections such as those caused by hepatitis B virus, abbreviated as HBV, hepatitis C virus, abbreviated as HCV, or human immunodeficiency virus, abbreviated as HIV, and diarrheal diseases. Infection with HIV previously was regarded as a reason to exclude a potential recipient from undergoing renal transplantation. Patients with primary immune disorders, such as chronic granulomatous disease, may now survive long-term but experience end-stage renal failure and require kidney transplantation. Successes with highly active antiretroviral therapy have improved long-term survival in HIV-infected pediatric patients, however, and have led clinicians, research scientists, and family members themselves to provide renal transplantation as a treatment for end-stage renal disease. Renal transplant candidates undergo peritoneal dialysis or hemodialysis, so a history of previous dialysis catheter-associated infections should be documented and any current infection should be treated and eliminated before transplantation is performed. Another focus of the history should include an exposure history for the patient's country of origin or foreign travel, especially to areas endemic for organisms such as Strongyloides stercoralis, Trypanosoma cruzi, Chagas disease, Coccidioides immitis, Blastomyces dermatitidis, or Histoplasma capsulatum, Zika virus or West Nile virus, and for diseases such as malaria and tuberculosis. Other important exposures include blood product transfusions, exposure to animals or plants, well water as a source of drinking water, and dietary habits, especially consumption of raw or undercooked eggs or meat or unpasteurized dairy products. Patients waiting for transplantation may become colonized with resistant organisms, including methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus, gram-negative multidrug-resistant bacteria, fluconazole-resistant or multidrug-resistant Candida species, and Clostridioides difficile. In children who are unimmunized, a careful history of routine childhood illnesses, including varicella, measles, mumps, and rubella, should be documented. The immunization history of the patient should be documented carefully and, if needed or indicated, updated before the patient undergoes transplantation. Ideally, children with chronic renal disease should be fully immunized before progression to end-stage renal disease for optimal immune response and protection during outbreaks of vaccine-preventable diseases. Vaccinations against tetanus, pertussis, and diphtheria, polysaccharide vaccines, such as those against pneumococcus and Haemophilus influenza type B, inactivated vaccines against polio and hepatitis A, and recombinant vaccines, such as those for hepatitis B, may be given or updated at any time before transplantation is performed. Meningococcal vaccine is indicated routinely now for specific age groups and for special outbreak situations. The live varicella vaccine is recommended for renal transplant candidates who have not had varicella. It should be given at least 2 to 4 weeks before transplantation is performed. The measles, mumps, rubella vaccine should be administered even earlier, preferably months before the patient undergoes transplantation. Measles immunity and immunity from other live virus vaccines may wane over time in renal transplant recipients. In addition, annual influenza vaccine and a tetanus booster every 10 years are recommended for patients who are renal transplant candidates or recipients. If the child is unable to be fully immunized before undergoing transplantation, the routine immunization schedule for the inactivated vaccines may be reinstituted after immunosuppression is decreased, which usually occurs 6 to 12 months after an uncomplicated transplant procedure. Live virus vaccines should be avoided in the post-transplant period in most instances. Reports of safe and effective vaccination with varicella vaccine in selected post-transplant patients have been published, however. Close contacts and family members of renal transplant candidates and recipients also should be immunized immunized and should receive the annual influenza vaccine. Other important points in the pre-transplant evaluation history include allergies or reactions to medications, especially antibiotics, and the use of immunosuppressive agents. Pre-transplant laboratory and diagnostic imaging evaluations for most renal transplant candidates should include a chest radiograph, urinalysis, and urine culture for bacteria. Baseline renal and liver function tests also should be performed. Serologic screening of the transplant recipient's status regarding organisms that may reactivate in the recipient or infect the recipient via the donor organ should be performed. Such screening should include tests for HSV, cytomegalovirus, CMV, varicella zoster virus, VZV, Epstein-Barr virus, EBV, human erythrovirus, parvovirus B19, Treponema pallidum, Toxoplasma gondii, hepatitis A, B, and C viruses, and HIV. Hepatitis E virus has also been shown to infect kidney transplant recipients, but the clinical significance of infection with hepatitis E virus in these patients is not clear. Transplant recipients who are seropositive for HSV or CMV usually receive antiviral prophylaxis during the peri-transplant period, whereas recipients seropositive for EBV may undergo post-transplant monitoring. It may be helpful to save an aliquot of the recipients and donors' serum in case unusual circumstances occur, such as infection with West Nile virus, WNV, or Zika virus. In CMV seropositive transplant candidates, baseline CMV quantitative DNA polymerase chain reaction (PCR) may be useful, and in EBV seropositive candidates, detection of EBV DNA by quantitative PCR may be helpful to document pre-transplant viral load, especially if post-transplant virologic monitoring is to be performed. Evaluation for active or latent tuberculosis infection should also be performed before the transplant. This evaluation should include a history of risk factors, including Bacillus calmette-guerin, BCG, vaccination, close contacts, country of origin, and a chest radiograph. In addition, a tuberculin skin test, TST, and interferon gamma release assay, IGR, quantiferin TB gold, quantiferin TB gold in tube, or T-spot TB, should be performed. Positive IGR assay results predict subsequent development of tuberculosis in adult kidney transplant recipients in whom latent tuberculosis infection cannot be detected by TST. General reviews of IGR assay results in adults with end-stage renal disease and in children also suggest that IGR assays are useful, but caution should be used when interpreting IGR test results in young children, especially when results are discordant with TST. The pre-transplant evaluation also is an opportunity for the infectious disease specialist to counsel the patient and family about measures that may reduce the transplant recipient's risk for development of infectious disease complications after the transplant. Patients who have an exposure, or even a suspected exposure, to varicella, that is chickenpox, or zoster, that is shingles, should contact their physicians immediately to see whether passive immunoprophylaxis with varicella zoster immunoglobulin or post-exposure antiviral therapy with acyclovir or valacyclovir is indicated. Plans for foreign travel to remote areas also should be discussed with the physician. The transplant recipient should consume only thoroughly cooked meat and seafood and thoroughly washed fresh fruits and vegetables. In addition, drinking water should be pure. Transplant recipients should avoid, if possible, changing cat litter boxes, aquariums, and bird cages and should avoid close contact with people who have viral respiratory tract illnesses. Finally, medical attention should be sought if fever occurs, especially if it is significant or persistent. Pause the video and carefully scrutinize box 73.1 summarizing guidelines for pre-transplant evaluation in pediatric kidney transplant before advancing to the next slide. We will now discuss post-transplant infectious complications. Infections occurring in the post-transplant period can be grouped into three main time frames: the first month post-transplant, early, 2 to 6 months post-transplant, middle, and 6 months post-transplant and onward, late. Although almost any organism or pathogen can infect a transplant recipient at any time, these time periods provide the clinician with a guide to the organisms and disease processes most commonly encountered, as shown in box 73.2. Infections occurring during the early post-transplant period. Infections occurring during the first month after renal transplantation usually are bacterial. Common sites of early infections include the wound, urinary tract, lungs, and indwelling intravascular catheters. We will now discuss wound infections. As with any surgical procedure, wound infections may develop in a renal transplant recipient. They occur in approximately 2% of renal transplant recipients and range in severity from a superficial wound infection easily treated with wound care and antimicrobial therapy to deep perinephric abscesses that may be difficult to treat and result in transplant nephrectomy. Wound infections are more likely to occur in patients with technical problems associated with the transplant surgery, including urinary leaks, vesicoureteral reflux, wound hematomas, or lymphoceles. Malnutrition during the pre-transplant period may impair wound healing and predispose the patient to development of wound infection. Open Penrose drains may increase the likelihood of introducing microorganisms into the wound, whereas closed suction drainage, such as with a Jackson-Pratt drain, may reduce this risk. In addition, prompt removal of all drains, usually within 5 days in most uncomplicated cases, and administration of prophylaxis with perioperative antibiotics may decrease the incidence of wound infections. Such measures are performed routinely in most renal transplant centers. The regimen usually is aimed at uropathogens and staphylococci. One dose generally is given before the transplant, and the regimen is continued for only 24 hours after the transplant. The diagnosis of a wound infection should be suspected if erythema, warmth, or discharge is present at the wound site or if an unexplained fever develops. Fluid may drain from the wound persistently, or a fluid collection or abscess may be seen on imaging of the deeper operative sites. The patient will be receiving immunosuppressive agents, however, and the findings may be unusual or the symptoms may be blunted. Any fluid or pus obtained should be stained and cultured for bacterial, mycobacterial, and fungal organisms. Organisms most likely to be identified as causes of wound infection include Staphylococci, Staphylococcus aureus, especially methicillin-resistant Staphylococcus aureus abbreviated as MRSA, but also coagulase-negative Staphylococci, Streptococci, and gram-negative enteric organisms. Unusual, multi-drug-resistant, or healthcare-associated bacterial pathogens and yeast, such as Candida albicans, also may cause wound infections after the transplant. In addition, case reports of wound and perinephric fluid collections infected with Mycoplasma hominis have been published. Appropriate antimicrobial therapy, initially broad spectrum and then ultimately tailored to the isolated organism and its susceptibility pattern, should be administered. The duration of appropriate antimicrobial therapy usually is 10 to 14 days or until the wound infection has resolved and the patient has been afebrile for 3 to 5 days. Deep abscesses or unusual organisms may require longer therapy. Pause the video and carefully scrutinize box 73.2 timetable for the occurrence of common infections and usual pathogens after kidney transplantation before advancing to the next slide. Pause the video and carefully scrutinize box 73.2 timetable for the occurrence of common infections and usual pathogens after kidney transplantation before advancing to the next slide. We will now switch gears to urinary tract infections. Urinary tract infections are common developments after renal transplantation and may affect 35% to 79% of renal transplant recipients. Post-transplant urinary tract infections are associated with acute and chronic graft dysfunction and may threaten renal graft survival. They may occur during the early, middle, or late post-transplant period and should be differentiated as afebrile and febrile. A urinary tract infection that is febrile and occurs during the early or early, middle post-transplant period, often is a severe illness complicated by pyelonephritis, urosepsis, metastatic foci of infection, allograft dysfunction, rejection, and relapse. Urinary tract infections occurring in the early post-transplant period are associated more often with graft loss than are urinary tract infections that occur later. The risk for developing an invasive urinary tract infection after undergoing renal transplantation seems to be increased in patients with prolonged bladder catheterization. Most catheters can be removed during the first few days after transplant. Dysfunctional bladder, uretero-vesical disorders with reflux, malnutrition, underlying disorders, renal stones, obstructive uropathy, or a contaminated cadaveric kidney. The inability of the bladder to empty completely or surgical complications, such as hematoma, reflux, or obstruction at the urinary anastomosis, are associated with urinary tract infections. In addition, young infants, especially infants who have vesicoureteral reflux, seem to have a high incidence of complicated urinary tract infections after a transplant procedure. Procedures that address the etiology and correct underlying physiologic and anatomic abnormalities of the bladder and ureters should be performed before transplantation to avoid or lessen development of complications associated with these problems. Newer surgical techniques allow children with reconstructed bladders to undergo successful renal transplantation with minimal risk for post-transplant development of urinary tract infections. The organisms most commonly isolated from patients with early-onset urinary tract infections include not only the typical gram-negative enteric bacteria, but also Enterococci, Staphylococci, and Pseudomonas aeruginosa. Unusual organisms, such as Streptococcus mitis, Serratia marcescens, and Corynebacterium ureolyticum, also can be found. Antimicrobial therapy should be tailored to the susceptibility pattern of the organism isolated from the urine. Because 30% of patients experiencing a urinary tract infection during the early post-transplant period may have recurrent urinary tract infections, a prolonged 6-week course of antibiotics usually is recommended to reduce the risk for developing a relapsing kidney infection. Antimicrobial prophylaxis may reduce the risk for developing a urinary tract infection. Trimethoprim sulfamethoxazole administered for the first 4 months after renal transplantation is effective in preventing most urinary tract infections and can provide cross-cover prophylaxis against pneumocystis jirovecii, pneumonia, and other diseases. We will now discuss pneumonia. Pneumonia can occur during the first month after renal transplantation and often is associated with prolonged endotracheal intubation. Gram-positive and gram-negative bacterial pathogens acquired from normal oropharyngeal flora and unusual or healthcare-associated multi-drug-resistant organisms predominate during the early post-transplant period. Legionella pneumophila and unusual Legionella species, such as Legionella mcdadei, Legionella bozemanei, and Legionella dimorphii, also have caused outbreaks of serious, life-threatening pneumonia in transplant recipients in some centers. Pneumocystis jirovecii can cause pneumonia in a transplant recipient during the early post-transplant period, but more often it is associated with disease after the first month post-transplant. Rare or unusual pathogens, such as Rhodococcus equi, may cause pneumonia in these patients. Patients with pneumonia usually have fever, chills, chest pain, malaise, change in tracheal secretions, cough, dyspnea, tachypnea, change in ventilatory status, rales or rhonchi on auscultation of the lungs, and pulmonary infiltrates evident on a chest radiograph. Pneumonia may be complicated by pleural effusion, empyema, or pulmonary abscess, and death may occur if pneumonia is severe and not diagnosed and treated promptly. Treatment with antibiotics effective against the bacterial pathogens isolated from culture of tracheal aspirates, bronchoalveolar lavage fluid, or lung tissue is appropriate. Next we will switch gears to bacteremia, fungemia, and sepsis. Bacteremia, fungemia, and sepsis occurring during the early post-transplant period often are associated with indwelling catheters. The urinary tract, surgical wound, or transplanted or native kidney also may be a source. Usual bacterial organisms such as coagulase-negative staphylococci or Staphylococcus aureus, unusual bacterial organisms, and yeasts such as Candida albicans and other Candida species may be involved. Listeria monocytogenes also may cause primary bacteremia or sepsis at any time after a kidney transplantation has been performed, but the greatest risk occurs during the early period. Complications include meningitis, and 10% of these patients may die. Renal transplant recipients also are at increased risk for development of bacteremia with Salmonella non-typhoidal species. Complications such as urinary tract infection, graft infection, peritonitis, abscesses, and meningitis can occur, and recurrences are common. Therapy for bacteremia, sepsis, or its complications is tailored to the susceptibility pattern of the organism isolated from the patient's blood. The duration of therapy for uncomplicated bacteremia usually is 10 to 14 days, but a longer course of treatment may be indicated if abscesses occur or an unusual organism is isolated. Removal of the indwelling catheter may be necessary to clear persistent bacteremia, and abscesses and other foci of infection should be drained. And now we will look at other bacterial diseases. Pediatric renal transplant recipients also seem to be at increased risk for development of antibiotic-associated colitis caused by Clostridioides difficile. Infection of a lymphocele with Pasteurella multocida has been reported, as has systemic infection with Bartonella henselae. A high index of suspicion always must be maintained when evaluating a transplant recipient for infection because the immunosuppression required to maintain the transplanted kidney predisposes the recipient to development of infection with unusual organisms. We will now discuss viral infections. Herpes simplex virus. Herpes simplex virus is the most common virus encountered during the early post-transplant period, although antiviral prophylaxis significantly reduces the risk for development of this infection. It occurs less frequently in pediatric, that is 8%, than in adult renal transplant recipients, that is 30%. Most herpes simplex virus infections encountered post-transplant are due to reactivation of the recipient's strain. However, primary or recurrent infection acquired from the renal allograft may occur, and primary infection from person-to-person transmission has been documented. Post-transplant herpes simplex virus infection may be asymptomatic or associated with disease, most frequently oral ulcers in pediatric patients. Genital and perianal ulcers may occur in adolescents and adults. Rarely, herpes simplex virus may cause disseminated cutaneous lesions or zoster-form eruptions. Herpes simplex virus esophagitis may be manifested as dysphagia, refusal to eat, irritability, and substernal chest pain, and it may complicate oral herpes simplex virus disease, especially if the oral mucosa has been traumatized by orogastric or nasogastric tubes. Acute severe hepatitis with hepatic necrosis, often accompanied by hypotension and disseminated intravascular coagulation, also can occur. Tracheobronchitis and pneumonitis may occur as a result of herpes simplex virus, primarily in patients with pneumonia caused by another pathogen and whose mucosa has been traumatized by endotracheal intubation. It is often severe and life-threatening, even with appropriate supportive care and antiviral therapy. Encephalitis also has been reported in renal transplant recipients. The diagnosis is made by isolation of herpes simplex virus in cell culture or detection of viral antigen by immunofluorescence or viral DNA by PCR in the end organ involved. Detection or isolation of herpes simplex virus in body secretions may represent asymptomatic shedding or disease and should be correlated clinically. If herpes simplex virus DNA by PCR is detected in blood, viremia is likely present and should be treated. Treatment with acyclovir is recommended for patients with mucocutaneous lesions, viremia, or end organ disease, and herpes simplex virus seropositive transplant recipients should receive acyclovir or valacyclovir prophylaxis during the peri-transplant period to prevent development of herpes simplex virus infection. Most patients receiving ganciclovir, valganciclovir, foscarnet, or C-dofovir for CMV prophylaxis also are protected against herpes simplex virus. We will now progress to other viruses. Seasonal viruses, especially winter respiratory viruses such as respiratory syncytial virus, influenza viruses, parainfluenza viruses, and adenoviruses, winter diarrhea viruses such as rotavirus, and late summer, early fall viruses such as the enteroviruses, can infect the transplant recipient during the early post-transplant period and cause disease. Such infections may be acquired from the family or the community, or they may occur from healthcare-associated exposures. Transplant recipients who may not be adequately protected by routine vaccination are at risk for severe influenza and its complications. In 2012, results of a study on oseltamivir prophylaxis with once-daily dosing for 12 weeks during periods of local influenza circulation showed that it was well tolerated and reduced influenza in adult and pediatric kidney and other solid organ transplant recipients. Oseltamivir-resistant influenza A was detected during the study period. Renal transplant recipients who are chronically infected with HBV or HCV may experience liver dysfunction during the early transplant period, but the late post-transplant period, beyond the first year, carries the greatest risk for progression of liver disease to cirrhosis. If a renal transplant recipient acquires HBV soon after undergoing transplantation, acute hepatitis can develop, often with death from liver failure. And now we will focus on non-infectious causes of fever. The most common non-infectious cause of fever in the first post-transplant month is allograft rejection. Fever often is the first sign of rejection, especially in children, and rejection should be considered if an infectious source of the fever is not identified. Another common non-infectious cause of fever early after transplantation is antilymphocyte antibody therapy, OKT3. The first 2 or 3 doses of OKT3 produce a release of cytokines, which cause fever and chills. In most patients, these symptoms resolve after the 3rd dose. Other non-infectious causes of fever during this period include drug reactions and pulmonary emboli. We will now discuss infections occurring during the middle post-transplant period. The cumulative effects of immunosuppression begin to be revealed during the period 2 to 6 months after transplantation. If a significant amount of anti-rejection therapy is required for multiple episodes of rejection, the effects may be more pronounced. Such immunosuppression allows classic opportunistic pathogens, such as CMV, Pneumocystis jirovecii, Toxoplasma gondii, Listeria monocytogenes, Aspergillus, and Nocardia, to evade immune surveillance and cause disease. Reactivation of organisms previously infecting the transplant recipient or the donor allograft, including Mycobacterium tuberculosis, HBV, HCV, HIV, Histoplasma capsulatum, and Coccidioides immitis, also may cause disease. In addition, an occult bacterial focus of infection that was not adequately identified and treated before the transplant may become apparent at this time and cause significant disease. We will now discuss herpes viruses. The herpes viridae, that is HSV types 1 and 2, CMV, EBV, VZV, and human herpes virus, HHV, type 6, 7, and 8, share the biologic properties of latency, reactivation, cell association, and oncogenicity, which renders them the most important group of pathogens that affect renal transplant recipients. HSV is more important during the early post-transplant period, whereas the other herpes viruses are important causes of morbidity and mortality during the middle and late post-transplant periods. We will now focus on cytomegalovirus. CMV may cause primary infection in a CMV seronegative transplant recipient through a renal allograft or blood product transfusion from a seropositive donor. Person-to-person transmission within the family or close community also is possible. Recurrent CMV infection develops in seropositive transplant recipients if the recipient's CMV strain becomes reactivated. The renal allograft from a seropositive donor also can be a source of reinfection to the recipient and produce active CMV infection or disease. CMV infection in renal transplant recipients may cause silent or asymptomatic infection, end organ diseases such as hepatitis, esophagitis, colitis, encephalitis, vasculitis, and retinitis, and systematic disease with persistent fever and leukopenia with thrombocytopenia. A case report also linked CMV infection with post-transplant occurrence of atypical hemolytic uremic syndrome that resolved with plasma exchange and ganciclovir antiviral therapy. It has been linked in some studies to allograft dysfunction and nephropathy. CMV also causes depressed cell-mediated immunity and impaired alveolar macrophage function, rendering the host more vulnerable to other opportunistic infections, such as fungal disease and Pneumocystis jirovecii pneumonia, and it serves as a cofactor for other viruses, such as EBV and HHV6 and HHV7. In addition, CMV is associated with acute and chronic rejection and allograft nephropathy and decreased long-term patient survival. Disease caused by CMV can be documented by isolation of CMV from tissue, detection of CMV DNA by PCR or similar assays in blood, bronchoalveolar fluid, or tissue. Isolation of PCR detection of CMV in urine or saliva documents active infection, but has little significance in diagnosis of organ disease. Serologic tests may document seroconversion in primary infections but generally should be reserved for pre-transplant screening only. Most transplant patients at risk for acquiring CMV disease, i.e., CMV seropositive recipients, D+, R+, or CMV seronegative recipients, D+, R-, who received a renal allograft from a seropositive donor, should be monitored by viral surveillance, usually by testing blood weekly for quantitative CMV DNA by PCR. Detection of significant levels of the virus by quantitative or semi-quantitative assay, or an increase from baseline levels, usually predicts CMV disease. Reduction of immunosuppression, along with preemptive antiviral therapy, generally is indicated and results in a decrease or resolution of CMV levels detected in blood. Despite receiving adequate antiviral therapy, some patients have persistently positive low, stable levels of CMV DNA by PCR, however, which should be interpreted within the clinical context. In some patients who otherwise appear well, the DNA may be fragmented and non-replicating, whereas in other patients with persistent symptoms and rising PCR levels, a strain of CMV resistant to one or more antiviral agents may be the cause. The antiviral agents currently available for the treatment of CMV disease and preemptive therapy for positive CMV markers include ganciclovir, valganciclovir, foscarnet, and cidofovir. For renal transplant patients with moderate to severe CMV-associated disease, 2 to 3 weeks of therapy with intravenous ganciclovir usually is adequate to treat disease. However, patients with CMV retinitis or repeat episodes of rejection may require maintenance therapy, usually with oral valganciclovir. Asymptomatic or mild CMV infections may respond to oral valganciclovir administered for 1 to 3 months. Preemptive therapy should be continued throughout the period of immunosuppression in patients who are severely immunosuppressed and at risk for development of CMV disease and recurrence, D+, R-. Foscarnet and cidofovir have significant renal toxicity and should be used with caution in renal transplant recipients. Prophylaxis for CMV disease is indicated in high-risk transplant recipients. D+, R-. Options include intravenous CMV immune globulin and oral valganciclovir. We will now discuss Epstein-Barr virus. Epstein-Barr virus infection in children who have received a renal transplant may be asymptomatic or may be associated with a variety of different syndromes, including a nonspecific viral syndrome, mononucleosis, smooth muscle tumors, leiomyoma, post-transplantation lymphoproliferative disorders, and lymphoma. Infection and disease may occur after primary and recurrent Epstein-Barr virus infection, but primary infection is more likely to occur and produce post-transplantation lymphoproliferative disorders in younger children than in adults who have received solid organ transplants. Epstein-Barr virus disease may affect 10% of pediatric renal transplant recipients and may develop 1 month to 5 or more years post-transplant, with the risk accumulating every year of post-transplant survival. Recurrence of post-transplantation lymphoproliferative disorders may also occur years after transplant and may involve unusual sites. Knowledge about post-transplant Epstein-Barr virus infection and disease is evolving, as graft survival has improved through more intense immunosuppressive regimens that preserve graft function, and other opportunistic infections, such as HSV, CMV, and P. girovechi, being successfully managed. Epstein-Barr virus has emerged as a formidable obstacle to successful solid organ transplantation in children. The estimated overall risk for development of serious life-threatening Epstein-Barr virus-associated illness is at least 4% and increases to 10% in children who experience a primary infection with Epstein-Barr virus after undergoing renal transplantation. Other risk factors for post-transplantation lymphoproliferative disorders in children who have received solid organ transplants include receipt of anti-lymphocyte therapy such as OKT3 for rejection, receipt of tacrolimus, sirolimus, or mycophenolate mofetil rather than cyclosporine for immunosuppression, and CMV or Epstein-Barr virus donor, recipient, D+, R-, mismatch. Nonspecific viral syndromes and mononucleosis occur during the earlier post-transplant period, whereas lymphoma and leiomyoma are more likely to be a manifestation during the late post-transplant period. Uncomplicated post-transplant mononucleosis is characterized by the self-limited illness of fever, pharyngitis, cervical adenopathy, and splenomegaly. The signs and symptoms of post-transplantation lymphoproliferative disorders vary, but often include persistent fever, weight loss, and generalized adenopathy. The disease frequently is multisystemic and progressive, and involvement of the neck, chest, lungs, gastrointestinal tract, liver, spleen, eyes, and brain, as well as lesions, may be detected by computed tomography of the head, neck, chest, and abdomen. The renal allograft also may be involved and show dysfunction. Lymphoma may be manifested as solid tumors in the renal allograft, lung, liver, spleen, brain, and soft tissues. Smooth muscle tumors, leiomyoma, frequently are multicentric and multifocal. They often occur in lung, liver, and spleen, but also may occur in unusual locations, including the brain and renal allograft. Laboratory diagnosis of post-transplant EBV-associated disease is based on detection by PCR of EBV DNA in circulating lymphocytes. Quantitative or semi-quantitative PCR assays may show increasing or persistently high copies of EBV DNA in the circulating lymphocytes of patients who are at risk for developing post-transplantation lymphoproliferative disorders. If end organ disease is observed, the diagnosis can be confirmed histopathologically by detection by PCR of EBV DNA in tissue or by in situ hybridization with an EBV-encoded RNA probe. The diseases associated with EBV also may be classified in the laboratory as polyclonal or monoclonal. Polyclonal illnesses seem to be more benign than monoclonal diseases, which often are associated with chromosomal abnormalities and malignant transformation. The virus cannot be cultivated by routine means. When studied by special culture techniques, EBV has been found frequently in the oropharyngeal secretions of seropositive transplant recipients and is not predictive of EBV-associated disease. Similarly, serologic approaches to establishing the diagnosis of EBV infection after a transplant procedure also are nonspecific and difficult to interpret in most patients unless the recipient clearly has sero-converted during the post-transplant period. Aggressive or intense treatment of uncomplicated EBV-associated viral syndrome or mononucleosis usually is unnecessary because these illnesses seem to be self-limited in most patients. Immunosuppression may be reduced, and acyclovir may be administered. The patient should be monitored carefully. If symptoms in the patient or EBV DNA levels in the blood persist or increase, post-transplantation lymphoproliferative disorders should be suspected and the diagnosis should be confirmed. Treatment of established post-transplantation lymphoproliferative disorders is challenging. Mortality rates are high, and the best results seem to occur if the disease is diagnosed by quantitative PCR viral load monitoring and serial imaging studies and treated aggressively. Preemptive therapy instituted when viral surveillance monitoring detects an increase in EBV DNA in circulating lymphocytes before end organ disease is evident also may be helpful in some patients. Reduction in immunosuppression remains the most widely recommended strategy, but a variety of regimens have been studied as well. Antiviral agents such as acyclovir and ganciclovir seem to reduce EBV replication early in the course of the disease process and may halt the progression of disease in some patients. Antiviral agents are ineffective, however, against latent EBV or cells that have been transformed by the virus. Interferon alpha, immunoglobulin, and anti-CD20 monoclonal antibody preparations such as rituximab have been used successfully in patients with established post-transplantation lymphoproliferative disorders. Experimental protocols evaluating adoptive immunotherapy in transplant recipients are ongoing. In addition, some experts suggest that administration of intense anti-CMV therapy with ganciclovir and CMV hyperimmune globulin may improve chances of survival in certain patients with post-transplantation lymphoproliferative disorders because CMV may serve as a cofactor in progression of disease caused by other members of the herpes viridae. Treatment of patients with lymphoma or leiomyoma includes a reduction in immunosuppression, chemotherapy, radiation therapy, and surgical resection of tumors. We will now discuss varicella-zoster virus. Varicella-zoster virus can cause primary, varicella, chickenpox, or reactivation, zoster, shingles, disease in a renal transplant recipient. Infection with varicella-zoster virus can occur at any time, but does so most often during the middle post-transplant period. Patients have fever and painful or pruritic vesicular skin lesions. Hepatitis, encephalitis, acute or chronic recurrent cerebral vasculitis and vasculopathy, and pneumonia also may occur, even in the absence of skin lesions, especially in an immunocompromised host. Varicella occurs more frequently in children, and zoster occurs more frequently in adolescent and adult transplant recipients. In contrast to other herpes viruses, varicella-zoster virus almost always is transmitted person to person or by aerosol in healthcare, family, and community settings. It rarely, if ever, has been linked to the transplanted allograft. Before the advent of routine immunization and antiviral therapy, infection with varicella-zoster virus was a major cause of morbidity and mortality in children receiving solid organ transplants. Untreated primary varicella may continue for several weeks and result in visceral dissemination, pneumonitis, hepatic necrosis, encephalitis, vasculitis with stroke, disseminated intravascular coagulation, hemorrhagic skin lesions, and death. Zoster in solid organ transplant recipients may remain localized to a dermatome, but it often disseminates beyond the dermatomal distribution and produces widespread skin lesions and even visceral dissemination. The diagnosis of varicella-zoster virus disease often is clinical, but it should be confirmed by isolation of varicella-zoster virus from fresh, vesicular skin lesions or detection of viral antigen by direct immunofluorescence assay on cells obtained by scraping the base of the skin lesion. Zank smear may show multinucleated giant cells, suggesting a viral infection, but it cannot differentiate varicella-zoster virus from HSV. Other pathogens, especially HSV, may mimic varicella-zoster virus disease, so establishing an accurate viral diagnosis is important. Varicella-zoster virus also may be detected by PCR-based DNA detection methods, which also may distinguish wild-type strains from the Oka vaccine strain of varicella-zoster virus. Qualitative and quantitative varicella-zoster virus PCR tests may be performed by reference and research laboratories. Establishing a serologic diagnosis of active varicella-zoster virus infection is difficult. Routine serologic screening performed in the pre-transplant period identifies patients who are seronegative and at risk for developing primary infection with varicella zoster virus. Treatment of established varicella zoster virus disease should be instituted as early as possible during the course of the illness because survival is improved if treatment begins before the 5th day of illness. Acyclovir is recommended for most renal transplant recipients experiencing either primary infection with varicella or zoster with dissemination. It is administered intravenously in high doses, 500 mg per meter squared per dose every 8 hours, if renal function is normal or adjusted for renal function as needed, for 5 to 10 days, or until new lesions have ceased to occur for 24 to 48 hours, old lesions have crusted, the fever has resolved, and disease has abated. Uncomplicated zoster or very mild primary varicella may be treated with oral acyclovir, famciclovir, or valacyclovir, provided that the patient is monitored carefully for clinical response. Ganciclovir, foscarnet, or cidofovir also provide cross-cover protection for most varicella zoster virus strains, if these antiviral agents are being administered for difficult CMV infections. If acyclovir-resistant varicella develops, then treatment with foscarnet or a combination of 2 or 3 antiviral agents may be necessary to control the infection. Prevention of post-transplant varicella zoster virus disease can be accomplished by several effective strategies, which should be discussed during the pre-transplant evaluation. Transplant recipients who were seronegative for varicella zoster virus during the pre-transplant evaluation should receive varicella vaccine before undergoing transplantation, if possible. Pre-transplant varicella vaccination is safe, beneficial, and cost-effective when administered to pediatric renal transplant candidates and in selected renal transplant recipients after a transplant procedure. Seronegative, unimmunized transplant recipients who are exposed to varicella or zoster during the post-transplant period should receive passive immunoprophylaxis with varicella zoster immunoglobulin, Vari-Zig. Preemptive therapy with oral acyclovir also is recommended by some experts in this situation because varicella zoster immunoglobulin does not prevent, but only attenuates, the post-exposure disease process. Finally, acyclovir, valacyclovir, ganciclovir, and valganciclovir administered prophylactically to transplant recipients who are seropositive for HSV or CMV also may provide protection against varicella zoster virus disease. We will now focus on human herpes viruses type 6, 7, and 8. Human herpes viruses types 6, 7, and 8 abbreviated as HHV6, HHV7, and HHV8 also infect renal transplant recipients by primary infection and by reactivation. Infection with these viruses becomes evident during the middle post-transplant period, but their roles in specific disease processes are unclear. HHV6 and HHV7 may act as cofactors in the progression of a disease, especially diseases caused by CMV and EBV. HHV8 is associated with Kaposi sarcoma after a transplant procedure in severely immunosuppressed adult renal transplant recipients, but to date it has not been appreciated as a major opportunistic pathogen in pediatric renal transplant recipients. HHV8 may be transmitted through the renal allograft or by blood product transfusion, or it can become reactivated in the recipient after transplant surgery. Next we will discuss polyomaviruses and papillomaviruses. Polyomaviruses. Human polyomaviruses, JC, BK, and SV40, frequently infect children and are present in urine and stool. They can be detected in the urine of 33% to 58% of renal transplant recipients and detected serologically in 56%, and they are found histopathologically and by PCR in blood, body fluids, and tissue in 8% to 13%. Knowledge about the roles that these viruses play in the outcome of renal transplant patients is evolving. The JC and BK polyomaviruses seem to have a significant impact on adult and pediatric renal transplant recipients. BK virus has been implicated in various syndromes, including ureteral stenosis, hemorrhagic or chronic cystitis, interstitial nephritis with graft failure, allograft nephropathy, BK-associated nephropathy, BKAN, and rejection in renal transplant recipients. Disease associated with these viruses most often occurs during the middle and late post-transplant periods. BK virus may be asymptomatic or cause increasing serum creatinine levels, cystitis, tubular necrosis, graft dysfunction, or allograft rejection. Risk factors for BKAN seem to include BK serostatus at the time of transplant, greater immunosuppression with use of mycophenolate mofetil, and concurrent CMV infection. Ciprofloxacin prophylaxis in kidney transplant recipients has been shown in one recent study to reduce BK virus infection and BKAN 3 months post-transplant, but not at 1 year post-transplant. BK virus historically was detected in urine by the presence of decoy cells, which are cells containing intranuclear viral inclusions. Currently, quantitative PCR assays that detect and quantify BK viral DNA are used for detection. BK viruria precedes BK viremia, which precedes BK nephropathy. Patients with BK-associated nephropathy may have BK viral DNA detected in the urine, blood, or plasma, and renal biopsy specimens may show characteristic viral inclusions. Most recently, quantitative PCR viral surveillance in blood or plasma has been shown in renal transplant recipients to be useful in predicting the development of BK nephropathy and in guiding pre-emptive antiviral and immunosuppressive strategies. Pediatric kidney transplant recipients who have increasing BK viremia levels should be managed preemptively with carefully monitored reduction of immunosuppression to prevent development of more serious complications of BKAN and graft rejection. This strategy usually results in reduction and then clearance of BK viremia and development of BK-specific cellular immunity coincident with BK virus clearance. Treatment of established BKAN includes a reduction in immunosuppression. Cidofovir and fluoroquinolones have activity against BK virus, and both have been used to treat BK virus infection and treat severe disease caused by BKAN. Intravenous immune globulin may also be of benefit. One report resulted in decrease of BK viremia and histologic resolution of BKAN. JC virus causes a rare syndrome called progressive multifocal leukoencephalopathy. It may be diagnosed by viral DNA detection using PCR-based assays available in reference and research laboratories or histopathologically by brain biopsy or autopsy examination. Successful treatment options for progressive multifocal leukoencephalopathy caused by JC virus are very limited, and most, if not all, patients die of progressive encephalopathy. An unusual case of JC virus encephalopathy transmitted from a donor kidney was successfully treated by removal of the donor organ. Next we will focus on papillomaviruses. Human papillomaviruses are common viruses that infect healthy children, adolescents, and adults. Adult renal transplant recipients are at increased risk for development of human papillomavirus-associated disease, such as cervical cancer and anogenital papillomas, whereas pediatric patients may develop numerous disfiguring cutaneous warts post-transplant, especially if they require severe immunosuppression. Malignant transformation of cutaneous warts caused by high-risk types has been documented. Treatment options are limited, but include physical removal of papillomas with laser and cryotherapy and careful reduction of immunosuppression. In one case series report, careful transition of the immunosuppression regimen from tacrolimus mycophenolate to tacrolimus leflunomide resulted in resolution of cutaneous warts in 4 pediatric renal transplant recipients. Human papillomavirus vaccines in patients with ESRD or renal transplant recipients are now recommended to be administered according to the standard immunization schedules. And now we will look at adenoviruses. Adenoviruses may infect pediatric renal transplant recipients at any time, but they are most likely to cause significant disease during the middle post-transplant period. They continue to emerge as a significant pathogen in pediatrics, including transplant recipients. They do not seem to play as important a role in renal transplant outcome, however, as do other viruses, such as the herpes viruses, and they currently are not as prominent in renal transplant recipients as they are in other transplant recipients, such as recipients of liver, lung, bone marrow, or stem cell transplants. Nonetheless, infections with adenoviruses in pediatric renal transplant recipients, when they occur, can be serious and include hemorrhagic cystitis, diarrhea, allograft nephropathy, pneumonia, hepatitis, and disseminated disease with multisystemic involvement. The diagnosis is made by isolation or detection by PCR of the virus in respiratory secretions, stool, urine, blood, or tissue. Rapid diagnosis may be accomplished within 30 to 60 minutes, using a rapid immunochromatographic assay that detects adenovirus antigens in eye secretions, respiratory samples, urine, and stool. Viral DNA also may be detected by PCR or quantitative PCR available in reference or research laboratories, and characteristic changes may be seen by histopathology in tissue. Adenovirus serotyping by neutralization assays and genotyping by PCR sequence-based assays are available in reference laboratories. Treatment of serious adenoviral disease primarily is supportive. Immunosuppression also may be reduced, when possible. Antiviral agents, such as ribavirin, ganciclovir, and C-dofovir, have activity against adenoviruses. Clinical reports of use of C-dofovir in traditional weekly dosing and intermittent renal sparing dosing is safe and well tolerated in pediatric transplant recipients with adenovirus disease. And now we will discuss human erythrovirus, parvovirus B19. Human erythrovirus has been reported to cause acute and chronic infection, manifesting as chronic anemia, red blood cell aplasia, and pancytopenia in renal transplant recipients. It also has been implicated in collapsing glomerulopathy and thrombotic microangiopathy in renal transplant recipients. Unusual manifestations, such as hepatic necrosis or central nervous system infection with vasculitis, also have been reported. Transmission most likely is person to person. However, some reports indicate that the virus may be transmitted by blood product transfusion or in the renal allograft. More recent reports suggest that the role that this virus plays in the outcome of renal transplant recipients may be more important than previously recognized, but systemic studies in pediatric patients have not been done. The diagnosis of acute infection with human erythrovirus is supported by erythrovirus-specific IgG seroconversion, detection of erythrovirus-specific IgM antibodies in serum, or detection of viral DNA in plasma, blood, body fluids, bone marrow, or tissue. The virus is not cultivatable in clinical virology laboratories that use routine cell cultures, but laboratories using special erythroid precursor cell lines may be able to cultivate erythrovirus for research purposes. No specific antiviral therapy is available, but anecdotal experience and case reports support a beneficial role for intravenous immunoglobulin and carefully monitored reduction in immunosuppression as management strategies to resolve erythrovirus viremia and associated end organ disease. We will now discuss West Nile virus. West Nile virus is a single-stranded RNA flavivirus, is an important pathogen worldwide. It usually is transmitted by mosquitoes and causes a febrile illness, viral meningoencephalomyelitis, and acute flaccid paralysis in the normal host. Renal transplant recipients may become infected with West Nile virus that is transmitted by the organ donor, by blood product transfusions, or naturally from mosquitoes. Routine screening of solid organ donors for West Nile virus infection has been discussed, but currently is not routinely performed. Infection with West Nile virus may manifest in the early post-transplant period if it is transmitted by the graft or blood products and, because of immunosuppression, produce severe febrile illnesses, seizures with status epilepticus, encephalitis, paralysis, and movement disorders. Death also may occur. A high index of suspicion is required. If West Nile virus is suspected, serum and cerebrospinal fluid should be sent for West Nile virus-specific IgG and IgM antibody testing. The virus also may be isolated in special cell cultures and detected by reverse transcriptase PCR-based assays or through metagenomic deep sequencing. Immunohistochemical staining may show West Nile virus proteins in tissues from biopsy or autopsy examination. Outcome in renal transplant recipients with West Nile virus disease improves with early establishment of the diagnosis and carefully managed reduction of immunosuppression. We will now progress to Zika virus. Zika virus is another flavivirus that has emerged as an important global pathogen and that may potentially impact kidney transplantation. Zika virus causes a febrile illness with rash, conjunctivitis, headache, malaise, or muscle and joint pain. It may be transmitted from mosquitoes or through sexual transmission, by blood transfusions, or from mother to baby and cause congenital infection and congenital Zika syndrome. The risk of Zika virus transmission through renal transplantation is unknown at this time, but the virus has been detected in the urine as well as the kidney and other organs of Zika-infected individuals. Routine screening of donors or recipients for Zika virus infection is not currently recommended unless there is a recent history of travel or exposure or illness associated with Zika virus within 6 months of kidney transplantation. Pre-transplant evaluation should include a careful travel history within 6 months to an area with active Zika virus transmission and a history for signs and symptoms associated with Zika virus infection in either the donor or the recipient. Since the risk of Zika virus transmission through renal transplantation is unknown at this time, Zika virus infection or exposure is not a contraindication to renal transplantation, but the risk of donor-derived infection should be balanced with the potential benefits of transplantation in each potential renal transplant recipient. We will now switch gears to Mycoplasma. Mycoplasma species commonly infect school-aged children. Children and adolescents who undergo renal transplantation also may experience respiratory tract infections with Mycoplasma pneumoniae and Mycoplasma hominis. The infection also may disseminate to extrapulmonary sites, causing hepatitis, septic arthritis, or perinephric fluid collections in pediatric renal transplant recipients. Mycoplasma species may be detected using special biphasic culture media or PCR-based assays. Serologic diagnosis is difficult to accomplish owing to cross-reactivity of antigens, producing the possibility of false positive reactions in some patients. Antimicrobial therapy with macrolide antibiotics, along with carefully managed reduction of immunosuppression, may be beneficial in selected patients. We will now discuss bacterial and mycobacterial diseases. Bacteria that commonly produce disease in renal transplant recipients during the middle post-transplant period include Listeria monocytogenes, which often causes sepsis or meningitis. Routine bacterial illnesses that were not identified and properly treated during the pre-transplant period also may emerge at this time and cause abscesses, sepsis syndrome, and death. Mycobacterial disease caused by Mycobacterium tuberculosis may occur at any time after transplantation, but it occurs most frequently during the middle post-transplant period. Mycobacterium tuberculosis causes disease in approximately 1% of renal transplant recipients in the developed continents, such as North America and Europe, and in 15% of renal transplant recipients in developing countries with a high prevalence of tuberculosis, such as India or Pakistan. Tuberculosis may develop in renal transplant recipients as a result of primary and reactivation infection in almost any site, and transmission from the renal allograft and reactivation in the native kidney have occurred. Mycobacterium tuberculosis may cause various diseases, including pulmonary infiltrates, cavitary lesions, adenopathy, cutaneous lesions, bone and joint disease, liver or spleen granulomas, and meningitis. Fever frequently is noted, and miliary or disseminated disease may occur, especially in young children. Because the TST is negative in most renal transplant recipients with active tuberculosis, the diagnosis is determined best by IgR assays, detection of acid-fast bacilli in smears from tissue or sputum, and isolation of Mycobacterium tuberculosis in cultures of gastric aspirates, sputum, tracheal secretions, spinal fluid, or tissue. The presence of granulomas in tissue also suggests the diagnosis of tuberculosis. Treatment of tuberculosis in a renal transplant recipient usually includes isoniazid, rifampin, and pyrazinamide for 1 year, although shorter courses may be acceptable in some patients. Other anti-tuberculous drugs may be added to or substituted for this standard regimen, depending on the disease process, the susceptibility pattern of the organism, and potential drug interactions. Because many anti-tuberculosis drugs are excreted by the kidney, doses may need to be adjusted in a renal transplant recipient. Because rifampin may interact with cyclosporine, levels of cyclosporine should be monitored closely to avoid rejection of the allograft. If a history of tuberculosis exposure is elicited during the pre-transplant evaluation, the transplant candidate should be evaluated for tuberculosis, including having a TST, IgR assay on blood and chest radiograph. All close contacts also should be investigated for evidence of having tuberculosis. Treatment is recommended if disease is discovered, and prophylaxis with isoniazid is indicated for most patients who have a recently positive result of a purified protein derivative, abbreviated as PPD, test on pre-transplant evaluation. A transplant recipient who receives an allograft from a donor with a history of tuberculosis or a positive TST or IgR assay also may be a candidate for prophylaxis with isoniazid after a transplant procedure. Atypical mycobacteria are ubiquitous non-tuberculous mycobacteria that can infect and produce disease in renal transplant recipients. They can cause disease during the middle post-transplant period and so are included here. Their effects usually do not become evident, however, until many years after the patient has undergone transplantation, during the late post-transplant period. Atypical mycobacteria that have been documented to cause disease in solid organ transplant recipients include Mycobacterium kansasi, Mycobacterium avium intracellulare, Mycobacterium fortuitum, Mycobacterium zenith, Mycobacterium haemophilum, Mycobacterium marinum, Mycobacterium chelonae, Mycobacterium abscessus, Mycobacterium gastri, Mycobacterium scrofulaceum, and Mycobacterium thermoresistabile. A high index of suspicion is necessary to detect these elusive pathogens. They should be considered as the cause of disease in patients with persistent cutaneous ulcers, abscesses, adenopathy, pulmonary nodules, chronic wound infections, or bone and joint disease after negative routine bacterial cultures have been obtained and the patient has failed to respond to standard antimicrobial therapy. Disseminated, multisystemic disease also can occur. Environmental sources of atypical mycobacteria include contaminated dialysis equipment, soil, and contaminated water in aquariums and pools. The diagnosis is established by isolation of non-tuberculous mycobacteria in fluid or tissue. Granulomas are not observed consistently in tissue, and acid-fast stains may be negative. Atypical non-tuberculous mycobacteria are difficult to treat, and treatment must be individualized to each patient. Strategies include reduction of immunosuppression and surgical debridement of localized disease. Antimicrobial therapy based on in vitro susceptibility testing of the isolate also should be administered, often for a prolonged period. We will now focus on nocardia. Nocardia asteroides is the most common nocardia SPP, causing illness in renal transplant recipients. However, other, more unusual nocardia SPP, including nocardia transvalensis, nocardia brasiliensis, nocardia nova, nocardia atitidiscaviarum, and nocardia farcinetsa, also have been shown to cause disease in solid organ transplant recipients. The most common manifestations of nocardial disease in transplant recipients are fever, cough, and pulmonary infiltrates. Pleural effusion, pulmonary nodules, and cavitary lesions also may occur. Cutaneous infection, adenitis, arthritis, meningitis with brain abscesses, and infection of the renal allograft also may occur. Nocardia species can be seen on gram and modified acid-fast stains of sputum, bronchoalveolar lavage fluid, abscess fluid, and tissue. They can be isolated on routine media, but may take longer than conventional bacteria to grow. Prolonged treatment with sulfonamides, alone or in combination with trimethoprim, is recommended. Amikacin and other antimicrobial agents may be added in selected patients with severe disease, provided that renal function is monitored closely. Trimethoprim sulfamethoxazole prophylaxis for urinary tract infection and pneumocystis jirovecii also may be effective in preventing disease caused by nocardia. We will now discuss fungal diseases. Fungal infections occur infrequently in renal transplant recipients relative to other solid organ transplant recipients. This lower rate of infection probably is related to technical procedures performed at the time of transplantation and the lower level of immunosuppression required to maintain most renal allografts. When they do occur, however, fungal infections often are serious and life-threatening. Fungal disease in a renal transplant recipient usually is manifested in one of two ways. 1. Pulmonary or disseminated disease caused by one of the environmental mycoses, such as Histoplasma capsulatum or Coccidioides immitis. Or 2. Opportunistic infection with fungi that rarely cause disease in a normal host, such as Candida species, Pneumocystis jirovecii, Aspergillus species, Cryptococcus neoformans, Nocardia species, and others. Travel to endemic areas increases a transplant recipient's risk for development of histoplasmosis and coccidioidomycosis and may be identified during the pre-transplant evaluation. Factors that increase a transplant recipient's risk for acquisition of opportunistic fungal disease include underlying conditions such as diabetes mellitus, repeated episodes of rejection, long-term administration of corticosteroids, prolonged use of antibiotics, and CMV infection. Similar to tuberculosis, invasive fungal disease can be a result of primary infection or reactivation infection with secondary dissemination. Pneumocystis jirovecii, currently classified as a fungus, may cause pneumonia in 10% of solid organ transplant recipients, most often during the first 6 months after a transplant procedure. It seems to occur more commonly in children than in adults and usually causes fever, dyspnea, tachypnea, hypoxemia, and a non-productive cough. Interstitial pulmonary infiltrates are typical findings, but almost any radiographic picture can be observed, and pneumothorax is common in severe disease. The diagnosis can be suspected clinically but is documented best by organisms being shown in lung biopsy specimens. Bronchoalveolar lavage may provide the diagnosis in some patients. Treatment with high-dose oral or intravenous trimethoprim sulfamethoxazole for 14 to 21 days is used most often. Intravenous pentamidine may be administered to selected patients, but renal function should be monitored carefully. Corticosteroids may be helpful in treating severe disease if given early in the course. Low-dose oral trimethoprim sulfamethoxazole provides effective prophylaxis against Pneumocystis jirovecii pneumonia and urinary tract infections and usually is administered to renal transplant recipients for at least 6 months post-transplant. Transplant recipients experiencing repeated episodes of rejection, allograft dysfunction, or CMV disease may require a longer period of prophylaxis. Aerosolized pentamidine is an alternative prophylaxis strategy for some patients. Candida species, especially Candida albicans, are the opportunistic fungi most frequently isolated in renal transplant recipients. Other Candida species isolated include Candida krusei, Candida glabrata, and Candida tropicalis, and others. The newly recognized Candida hemolinae and Candida auris, potentially fatal, multi-drug-resistant species of Candida causing healthcare-associated bloodstream infections, have not yet been documented in pediatric renal transplant recipients, but remain a potential risk for these patients. Most fungal infections caused by Candida species occur during the first 2 months after transplant surgery, usually at the site of indwelling intravascular and urinary catheters. Esophagitis, abscesses, and arthritis also can develop, and endocarditis with metastatic foci can occur if the fungemia persists. Other opportunistic fungi such as Aspergillus most often cause sinusitis and pulmonary disease, and, because of its angio-invasive nature, Aspergillus often disseminates and causes lesions in the liver, spleen, and brain. A thorough search for metastatic foci always should be undertaken when a primary focus of invasive fungal disease is documented. Cryptococcus neoformans usually causes cutaneous lesions or abscesses and pneumonia with pleural effusion, but meningitis, arthritis, and pyelonephritis also can occur. Exposure to soil or bird droppings provides an epidemiologic clue to the diagnosis. In addition, the zygomycetes, including Rhizopus, Mucor, Rhizomucor, and Absidia species, can cause disease in solid organ transplant recipients. They most often cause cutaneous, rhinocerebral, or pulmonary disease or brain abscesses in renal transplant patients. Cutaneous and soft tissue infections, wound infections, and gastrointestinal disease with perforation also have been described. The zygomycetes, similar to Aspergillus, are angio-invasive and disseminate via the bloodstream to cause disease, which often is severe. A variety of unusual fungi, such as Pachylomyces, Fusarium, and Bipolarize, have been shown to cause cutaneous infection, usually at the site of indwelling catheters, and Hansenula anomala reportedly has caused urinary tract infection in a renal transplant recipient. The endemic dimorphic fungi include Histoplasma capsulatum, Coccidioides immitis, Blastomyces dermatitidis, and Paracoccidioides brasiliensis. Infection with these organisms can occur at any time after the patient has undergone transplantation, but usually occurs during the intermediate post-transplant period. These organisms usually are noted in renal transplant recipients who reside in endemic areas. Histoplasmosis is endemic in the central part of the United States and many foreign countries, and nosocomial outbreaks have occurred during hospital construction projects. Fever, chills, and cough are the usual initial signs. Skin lesions, hepatosplenomegaly, and meningitis also can occur. Pancytopenia often is present as well, and the organism frequently is found in the bone marrow of patients with disseminated disease. Coccidioidomycosis is endemic in the southwestern portion of the United States and northern Mexico. It usually is manifested as fever, cough, and pulmonary infiltrates, but extrapulmonary dissemination frequently occurs. Blastomycosis is endemic in the southern United States, along the Mississippi and Ohio River valleys, and in the Great Lakes area. It is a rare development after renal transplantation, but most often causes lung and skin lesions. Paracoccidioidomycosis rarely has been reported in renal transplant recipients. The diagnosis of invasive fungal disease is established best by isolating the fungus from sputum or tracheal aspirate, bone marrow, tissue, or fluid. Serum tests and bronchoalveolar lavage for galactomannan and 1,3-beta-D-glucan levels support the diagnosis of invasive fungal disease, and DNA PCR tests on serum and bronchoalveolar lavage fluid also may now be performed to detect Candida species and other fungi. Cryptococcus neoformans also may be isolated from urine. Fungal-specific serology and tests for cryptococcal antigen may support the diagnosis of cryptococcal infection. Fungal identification and susceptibility testing now can be performed in clinical and reference laboratories and should be used to guide therapy whenever possible. Amphotericin B usually is used to treat most invasive fungal disease in transplant recipients, and the deoxycholate, lipid complex, or liposomal forms can be used, provided that renal function is monitored closely. Flucytosine may have additive or synergistic effects against many yeasts and fungi. The azole antifungal agents are not nephrotoxic and are used in renal transplant recipients whenever possible. Many Candida species are susceptible to fluconazole, although resistance is emerging in all Candida species and is present in a high percentage of Candida krusei and Candida glabrata. Itraconazole and voriconazole may be effective against other fungi, such as Aspergillus. Voriconazole is the treatment of choice for most Aspergillus infections. Itraconazole should be used with caution because it has variable oral absorption and may interact with cyclosporine. Caspofungin, an echinocandin, also has activity against most Candida species and a variety of opportunistic fungi, including some species of Aspergillus. The triazole posaconazole and the echinocandin micafungin have also been used successfully in pediatric renal transplant recipients with invasive fungal disease. Surgical resection or drainage of abscesses, avascular cavities, or effusions may be required to treat some forms of invasive fungal disease of the lungs, liver, or spleen. Carefully monitored reduction in immunosuppression also may help the host recover from invasive fungal disease. We will now focus on parasitic infections. The parasites most commonly encountered in renal transplant recipients during the intermediate post-transplant period are Toxoplasma gondii, Strongyloides stercoralis, and Trypanosoma cruzi. These infections occur most often in adults. Children also may be infected with routine parasites such as Enterobius vermicularis, Ascaris, Giardia, and others before a transplant operation. Other parasitic infections that may be found in renal transplant recipients include leishmaniasis, schistosomiasis, and malaria. Renal transplant recipients seem to be at much lower risk for acquisition of parasitic diseases than are other solid organ transplant recipients. Infection with Toxoplasma gondii usually occurs as a result of reactivation of latent disease in the donor allograft or recipient. It is encountered most frequently in heart transplant recipients, but any solid organ recipient, including renal transplant patients, may be affected. Clinical manifestations of infection with Toxoplasma gondii include focal meningoencephalitis, brain abscesses, pneumonia, myocarditis, pericarditis, hepatitis, and retinochoroiditis. The diagnosis may be made by demonstration of the organism in tissue by histopathology, detection of DNA by PCR in body fluids or tissue, or serologically by detection of high titers of IgG and specific IgM antibody to Toxoplasma gondii. Treatment with pyrimethamine, sulfadiazine, and folinic acid usually is recommended. However, some patients also may respond to clindamycin. Routine prophylaxis with trimethoprim sulfamethoxazole for urinary tract infection and Pneumocystis jirovecii infection may help prevent disease with Toxoplasma gondii. Stercoralis is an important pathogen in adult transplant recipients, but it is rarely, if ever, a significant problem in pediatric patients. Because S. stercoralis can be maintained in the human intestinal tract for decades, it can disseminate and cause serious disease in transplant recipients who were infected before the procedure. A complete blood cell count for eosinophilia should be obtained, and stool and other specimens should be examined for rhabditiform larvae if the pre-transplant evaluation reveals travel to endemic areas. Thiabendazole should be given before transplantation is performed if Strongyloides stercoralis infection has been documented or is suspected. Trypanosoma cruzi, the cause of Chagas disease, rarely has been transmitted by renal transplantation. We will now discuss infections occurring during the late post-transplant period. Infections occurring 6 months or more after the patient has undergone renal transplantation usually are less severe than infections experienced in the earlier periods, especially if the level of immunosuppressive therapy is low and the allograft is functioning well. Constant vigilance for healthcare-associated and community-acquired viral and bacterial diseases and unusual infections should continue, however. Chronic rejection or repeated episodes of acute rejection complicated by allograft dysfunction predispose the patient to development of more serious opportunistic infections, similar to infections encountered during the first 6 months after a transplant. Urinary tract infections that develop during this period, in contrast to urinary tract infections in the early post-transplant period, usually are benign, especially if the patient is febrile, and may be treated with conventional antimicrobial therapy in most instances if they do not seem to threaten the function of the allograft or the patient's survival. Patients also may experience community-acquired infections with respiratory viruses, such as influenza virus and respiratory syncytial virus, and with bacteria, especially Streptococcus pneumoniae, Pneumococcus, or Staphylococcus aureus. These common community-acquired bacterial pathogens may be resistant to usual beta-lactam antibiotics. In addition, patients vaccinated with 7-valent or 23-valent pneumococcal vaccines still may acquire invasive pneumococcal disease with emerging, non-vaccine serotypes, such as 19A and 3A. These serotypes often are also multi-drug resistant. Opportunistic viral infections encountered during this period are zoster or, rarely, CMV retinitis. The risk for developing post-transplantation lymphoproliferative disorders and BKAN also persists during this late post-transplant period. Renal transplant recipients may be chronically infected with HBV or HCV before a transplant is performed. Increased risk for mortality from fulminant hepatitis with hepatic failure may occur during the early pre-transplant period, and chronic liver disease, cirrhosis, and liver failure may be seen 10 years or more after renal transplantation has been performed in hepatitis B surface antigen, HBsAg, positive recipients. All transplant recipients who are not immune to HBV should receive HBV vaccine before transplantation. Most experts agree that renal allografts from HBsAg positive donors should not be used, but the decision to perform renal transplantation in recipients who are HBsAg positive is controversial and must be made on an individualized basis. Renal transplant recipients who are infected with HCV before the transplant usually do well during the early post-transplant period, but long-term survival is poorer than in recipients who are not infected with HCV. Not only can chronic liver disease develop, but also membranoproliferative glomerulonephritis has been reported in renal transplant recipients infected with HCV. Despite these risks, however, most experts do not consider infection with HCV a contraindication for renal transplantation in patients with ESRD. Hepatitis G virus also has been detected in the serum of renal transplant recipients, and at least one association with membranous glomerulonephritis has been reported. The role of HGV in clinical disease in renal transplant recipients is not established, however. HIV may be transmitted by kidney transplantation, despite routine screening of donors of blood and organs. A transplant recipient also may become infected with HIV after undergoing transplantation. Shortly after a patient has undergone transplantation, HIV infection may cause fever and a mononucleosis-like syndrome. Complications of acquired immunodeficiency syndrome may develop during the late transplant period. HIV-infected patients with ESRD are no longer excluded from receiving renal transplantation, because recent studies have shown successful outcomes. Thank you.